Hi, I'm Dr. David Light. I'm a partner at Nibrow Plastic Surgery and a board member at breastreconstruction.org. And you're joining us for an Instagram Live. We're going to have Dr. Corinne Men joining us in just a moment or two. And you're going to have opportunities. Here she is. Hi, Dr. Men. How
Hello,
are you?
Dr. Light. Nice to see you.
Nice to see you as well. Thank you for joining.
Yes, of course. Love to do this. So thanks for having me.
Absolutely. So why don't we get started? If you'd like to tell us a little bit about your practice and your
Sure.
specialty.
Yeah. So I'm a board certified OBGYN and now a menopause specialist, and I dedicate my practice to menopause management, breast cancer survivorship, also do a lot of work with BRCA previvors. And I see patients on the Alloy platform, so alloy.com, and and provide menopause care. But this is really personal for me, and we've talked about it in our past Instagram lives that we've done. But I come at this from a personal experience too, because I'm a long-term breast cancer survivor and a BRCA carrier. Was diagnosed during my residency when I was only 28 years old with stage 2A breast cancer. So 23 years later, I'm here, and I've kind of been there, done that in terms of all the different treatments and surgeries and reconstruction, and things have come a long way in 23 years. Um, but I see in the community of patients out there, there's a lot of questions and need, especially with expanding options for reconstruction and certainly radiation, how that's changed over time. And it's really overwhelming for patients to navigate. So it's so great the
It
work
is.
that you were doing personally in your own practice. I know, as well as with breast cancer or breastreconstruction.org.
Thank
So
you.
yeah, so we're gonna get into it all today, right?
Sounds good.
Yeah.
Let's do it.
So I know that, like, I know from our last session where we talked about the different reconstruction options that
Hmm.
patients have, there was a very, very high volume of questions about radiation, right?
Correct. Yep. Yep.
Um, and radiation influences sometimes the techniques that you use, the timing, etc.
Definitely.
Um, and before I ask you questions, I'll just say, like, one of the interesting things that we were talking about offline is that when I was first diagnosed, and they did not know I carried the BRCA gene at that time, um, they were giving me an option of lumpectomy or mastectomy. And my plastic surgeon, who I consulted with, because I was, trying to decide, they said, why don't you go and speak to a radiation oncologist? Because they wanted me to understand, if I chose lumpectomy, what it would mean for me to have radiation so that I could really make an informed decision. And that was one of the best pieces of advice I got personally. And I don't think that always happens. So in the end, I did not have radiation because I had a mastectomy, but lots of my patients have. And it is definitely, the trend has been, especially with early stage breast cancer, DCIS, real trend towards offering breast conserving surgery, but it
Hmm.
has those implications. So do you want to just, like, talk about why radiation in general impacts reconstruction?
Sure.
General
Absolutely.
principles? Yeah.
Yeah. So I think it really has to do with the effects that radiation has on tissue. And the important thing to remember, first off, is those effects are permanent. So radiation causes changes to the skin and also the deeper tissue of the breast. Um, and if we are doing a natural tissue reconstruction and that gets radiated, it will affect the natural tissue reconstruction as well, like a deep flap. So if we start from superficial and then work deep on the breast, the first thing that we encounter is the skin. So what can happen to the skin after radiation? You can get hyperpigmentation, or the skin gets a little bit darker. Now that does tend to fade a little bit with time, but for some patients there will be a permanent sort of change in the tone of the skin. It can also cause the skin to contract or get tighter and also thin. With respect to the deeper tissue in the breast, you can have loss of volume. So whether it's the fatty tissue of the breast or the fatty tissue in a natural tissue flap like a deep flap, the fat can sort of contract as well, or atrophy. So we lose volume in the breast. That can lead to an asymmetry in the breast size, because usually it is just one breast getting radiated. It's pretty rare to have bilateral radiation. And so that certainly poses a challenge for our reconstructions and trying to maintain as much symmetry. The other thing that can happen to the tissue is the tissue, the fatty tissue can become firm. It's something called fat necrosis. And that change is also permanent. And so we, as plastic surgeons, can try and um, break that scar tissue up to soften it, but many times it needs to be removed if it's a sizable area and it's uncomfortable for the patient. And so that can lead to a volume deficiency or a contour abnormality in the breast, which then needs to be corrected. So I think that your plastic surgeon gave you a very good piece of advice. I'm happy to say in our community, I'm seeing breast surgeons advise patients to see a radiation oncologist prior to surgery, as well as a medical oncologist, because not only does radiation changes have permanent effects, but to your point, I think it's very important that patients understand what the effects of chemo are, what the effects of hormone blocking therapies, especially if the patient is very young and they're going to be on it for years. So all of these play a very vital role into, I think, a patient's decision-making process. And the only way that you can make a good decision is if you have all of the information. So I think these
100%.
classically, it was you saw the breast surgeon, you saw the plastic surgeon, and then you would see the radiation the radiation and medical oncologist later. But I think getting them involved earlier so that they can pre-educate patients on what it's like to have these treatments is really critical, because you're making decisions early on that have a ripple effect. And so if you
100%.
choose, right, if you choose a lumpectomy, you will have radiation. So really important that you understand, the effects of radiation and what's involved for you to make an educated decision up
Yeah.
front.
I used to tell patients, it's like choose your own adventure book. Like if you choose
Yes.
this, then you go down this path. But if you
Yes.
choose this, you go down this. And it was really interesting. I hear this often from people who tell me they're diagnosed with DCIS or a very small breast cancer, and they're thinking like, oh my goodness, I just want to have a mastectomy. That's what I want to do. And I understand that very emotional
Yes.
sentiment. All right. And I think that emotional and that kind of fear is very, very valid, as well as the concerns for long-term repercussions, meaning I have to go for continued, breast screening and
Mm-hmm.
mammograms. But also I might, if I had a mastectomy, it may not need radiation. And if I had something like DCIS, which is if you have a mastectomy, it's treated. That's it. You
Right.
don't get radiation and you don't get hormone blockers like tamoxifen. And
Mm-hmm.
so that's where, to your point, seeing that medical oncologist so that you can know, like, well, what would it mean
Mm-hmm.
to have 5 years of hormone blockers? And I have seen patients who have chosen lumpectomy and radiation, and then they're like, okay, this breast is asymmetric. I had to deal with this radiation, and no one told me that if I would have just done a mastectomy with a nice reconstruction from someone like you, Dr. Light, that I would be
Right.
done and I wouldn't
Right.
have to spend 5, sometimes longer on, you know,
Yeah.
medical menopause. So, you know, now listen, there's many, many patients where the values are different, that they would really
A
value saving their
hundred
breast. And that's
percent.
just as valid. But you can't make that decision until the full
Right.
picture, correct?
Right. And
Yeah.
I'm not making the argument that everyone should have a
Oh, no,
mastectomy.
not at
Uh,
all. No.
I'm simply making the argument that you really need to be educated on
Yes.
all of the aspects of your journey, as you mentioned, that adventure path that you're picking,
Yes.
so that it's an educated decision.
100%. And so, and so you alluded to, like, so if you have a lumpectomy and you have an invasive cancer, very likely,
Hmm.
99% of the time, you're going to have radiation, right?
Hmm.
Um, but there are some patients who have a mastectomy,
Hmm.
right? Who, they wake up from surgery and they get their pathology back a few weeks later, and they still, in some small cases, might also still need
Radiation.
radiation, right?
Correct.
What
Yep.
are some of the reasons why someone who had a mastectomy might need radiation still?
It can be because of positive lymph nodes.
Mhm.
And it used to be that it was 1 to 3. Now there's discussion of even doing radiation if there's one lymph node, especially for a younger patient,
Yeah.
for older patients in, in their mid to late 70s, sometimes radiation can be omitted even if they were younger, they would be a candidate, but age sort of takes them out of it because studies have shown there's really no benefit. But so positive lymph nodes is one. Inability to clear a margin. So if the breast skin is positive, um, and size of the tumor.
So now, if someone is in that situation, how do you determine, and they're having reconstruction, how does it affect the timing
Mhm.
of when you would offer those different reconstruction options?
Sure. So I think it depends which reconstruction pathway you're going to go down. So we'll start with implants first. So with implants, if I know the patient is going to need radiation, my preference is to put in a tissue expander first. And there has been in the plastic surgery literature, going back 15 years, maybe even longer, there's been an argument as to when to perform radiation and at what stage. So with a tissue expander, classically, you put a tissue expander in, and then if you don't need radiation, then whether it's 2 or 3 months, surgeon's preference, later you're switched out to the more permanent implant. And so the there is one school of thought to do the radiation after after the tissue expander before the implant. There's another school of thought to switch to an implant sooner and then radiate the final reconstruction. And radiating the final reconstruction, the reason that some surgeons prefer that is they don't want to operate on radiated skin. Operating on radiated skin has a higher wound healing complication, a higher infection rate, and so their thought is to try and avoid that. The problem with that is radiation is causing permanent changes to the skin, and it also increases your chance of something called capsular contracture. And in some studies, it's as high as 30 to 40%. And so capsular contracture refers to excess scar tissue that forms around an implant, which can contract or tighten. That usually causes the implant to change shape and often take a higher position on the chest. And in some cases, it's even uncomfortable. So there's different grades. A grade 3 capsular contracture means that the breast shape has changed. A grade 4 capsular contracture means that it's actually painful for the patient. And in those cases, we're usually reoperating. My preference is to put the tissue expander in and then radiate the tissue expander. I know that there's a little bit of a higher risk with wound healing complications. Studies have shown that if you wait somewhere between 4 to 6 months, depending on the study, my sort of rule is 6 months. So I'll wait 6 months after radiation is complete before going back to put the final implant in. And I prefer that because it's giving me another chance, if there's been a capsular contracture, to intervene, to try and improve the shape of the breast, to remove some of that capsule, to make adjustments to try and improve symmetry as much as possible.
Yeah.
With natural tissue reconstructions, there's two school of thoughts there as well. One is you just move right to, for example, a deep flap, and you radiate the deep flap. And that is totally fine. And that has, I've done that in my practice before. In fact, where I did my fellowship, that was commonplace. All of the deep flaps were radiated. My preference in practice, though, is to actually put a tissue expander in first as well, if I know the patient is going to get radiated. And that's to avoid the permanent changes that can happen to my flap, which once those changes happen, you can't go back. So the way that I explain it to the patient is, yes, it's an extra procedure. However, especially for your younger patients, your 30-year-olds, your 40-year-olds, even 50-year-olds, you're going to have this reconstruction for years. And so to me, it's a little bit of investment in time and an extra procedure to make sure that you have a soft reconstruction where the skin is radiated, but the actual reconstruction has not been radiated. And so I think that's more comfortable for the patient. There's advantages to shape. There's actually advantages to having non-radiated tissue under radiated tissue. It can actually improve the quality of the radiated skin. And so I think there's a number of different advantages there. The other advantage, there's a, there's actually a third option with implants, and that's to do a direct to implant right away
Hmm.
and radiate the implant. Just
Hmm.
skip a tissue expander completely. The reason why I like to put a tissue expander in is because tissue expanders are adjustable. And so I've learned from speaking to my radiation oncology colleagues, they like tissue expanders because, especially for a cancer that's on the left side of the chest, there, if the right breast has an implant in, it's not adjustable. If it has a tissue expander in, I can decrease the volume in the right breast so that they can angle the radiation in a way that targets the breast
Hmm.
and avoids the lungs and the heart. And so
Interesting.
to me, that's a huge advantage. If there's an implant in and we can't adjust it, they have to steepen the angle for the radiation. And if you think about it now, that's pointing right towards the chest instead of the breast. And when I mean chest, I
Yeah.
mean the heart and
So
lungs.
you're
And so,
saying the unaffected breast, you're
yes,
saying.
is the
So
one
like
that
say
gets
someone who
adjusted.
has a genetic mutation like BRCA
Mhm.
and they're having a bilateral or they've just chosen to, you're saying that you might actually make the breast a bit unequal at first
In
to
preparation
accommodate
for
a
radiation.
better radiation angle.
Correct,
That,
100%.
that's really interesting because one of the things that the radiation oncologist said to me, because I was so young,
Mhm.
they said, listen, you'll tolerate radiation. You're young, your skin's healthy, all of those things, you're healthy. But there are long-term implications
Yeah.
to being radiated.
Hmm.
And
There are.
when you're radiated at 65, all right, that 20-year, implication when you're 85 may not mean as much as when you're 30, and your 20-year implication of radiation, like late effects of radiation in terms of heart, lung, other
Mhm.
things. Well, at 20 years, you're only 50, right?
Right.
So I think that's like another reason why it's important to speak to these radiation oncologists.
Yeah.
That angle of that's something I did not know. That's really interesting. So, all right, so someone going into radiation and they want to know, okay, I'm going to do my radiation timing as we've decided, whatever timing that is, from your standpoint as the expert in cosmetic and plastic surgery, what's the best skincare tips that you would tell that patient she should do while she's under getting radiation?
So I think keeping the skin well moisturized. Each radiation oncologist sort of has their
Hmm.
preference, whether it's Aquaphor or other products. I'm not aware of any studies that have compared that have shown a benefit for any specific product, but I think just moisturizing. You want that skin to be healthy, to be supple. You don't want any drying. You don't want any cracking of the skin. The skin is inflamed and vulnerable, and certainly any breakdown in the skin, which could potentially allow any bacteria in, result in a cellulitis, is the last thing you want at that point. So just keeping the skin well moisturized with whatever product works for you, I think is the most helpful.
And it's interesting. What do you see? And I know this answer is it really probably depends on the patient, but in terms of women getting adjuvant endocrine therapy, like being put into medical menopause or surgical menopause, and then getting an aromatase inhibitor that further lowers their estrogen levels. In practice, do you generally see those endocrine treatments being started after the patient is had her radiation in a lot of her surgeries, or are they being started kind of in the midst of that?
Um, I've seen both. I think for the most part, it started after.
Yeah,
Yeah,
yeah.
I think that traditionally chemo will come first, followed by radiation, and then whatever hormonal or immunotherapy that they're going to be on is started after that. For the most part, I think it's happening afterwards.
Yeah, and that's good because it's interesting that and it's something like a lot of plastic surgeons or people don't talk about,
Mhm.
but like we need to talk about like the estrogen deprivation on skin healing. And I think this has come up. I had a couple of patients who had, revisions of their plastic surgery, their reconstruction at a number of years down the road. And now at this point, they may have been 3, 4, even longer years on aromatase inhibitors and estrogen deprivation. Their skin has gotten thinner and drier, and no one tells them a big part of why is because of estrogen deprivation. And I actually, before this, I like looked up, and there's, I mean, we know what estrogen loss does to skin and
Yeah,
wound healing. It increases inflammation, it decreases collagen, all of these things. So I do think it's like an interesting thing for us to, I had a patient who was like, my surgeon was so surprised because I'm young. They can't believe I had wound breakdown. I'm like, you've been on an aromatase inhibitor for almost like 8 years. I'm like, your collagen is crap right now. Like, let's be honest, like that's what
yeah,
happens, right? So I think we have to be like kind of aware that that's like also another risk factor for like wound breakdown, right?
a hundred
Which I
percent.
think is interesting.
And no one actually ever talks about it. You know,
No, it's crazy.
it's sort of something that's just. I think that you know, the hormonal medications are certainly critical. They play a role, but there's a lot of the side effects are sometimes not talked about or
Yeah.
downplayed just a little bit. And you know, I think it's important for patients to at least be aware. You know, when we talk about implants, there's, you know, many specific risk factors that are present with implants that aren't present with natural tissue
Yeah.
reconstructions. And it doesn't prevent us from using the implant, but it's really critical that the patient is aware of it
Yeah.
so that they know, like, okay, I'm experiencing this. I should come in to be seen because that could be a sign that something's going on. And
Yeah.
so, you know, for all of these treatments, and again, it just gets back to that comment that we made before, that you know, in order for the patient to be aware and playing an active role, that they need to be educated.
They do. And, you know, I also think that when women are deciding about their reconstruction and their radiation and all these different things, they feel like it's a real urgent matter. And I get it. I was there once too. I was crying and screaming in the poor
Yeah,
plastic surgeon's office, being like, "You've got to get me on the OR schedule. You can't tell me your next OR date is in 4 weeks. I need this now." I was like so urgent. I think they just felt bad for me because I was only 28. So they got me in. But I look back and I realize, like, actually this is a marathon, not a sprint. And as much as you want to get that breast cancer surgery done and out, honestly, if it means taking a week, 2 weeks, 3 weeks, in most cases, I mean, of course, there are certain breast cancers
sure.
that are more advanced and aggressive, and your doctors are going to push you or soon. But in most cases, you have a few weeks to shop around, ask the questions, get to hear from everybody on the team, like you alluded to. And it's really important to remind yourself that if you're listening to this or you know someone who's newly diagnosed, take a deep breath,
Yes.
one more week, or like one extra procedure. Like if you've got to do a two-step by doing a tissue expander, and not doing direct to implant, although that could be fine for certain people, right? It's okay. Give
Correct.
yourself a little grace and peace. And it feels like a five-alarm fire, but it's not. You can take a little bit of
Yeah.
time, right?
I think the key is progressing. And so I
Yes.
think that, you know, there are metrics from the time of diagnosis
Mhm.
to when a patient actually begins treatment, but
Yes,
it's actually a reasonable amount of
it
time.
is.
We're talking on, you know, in terms of a couple of months, not, you know, a couple of days.
Yeah.
And so it's important that you do take a deep breath, you do explore options, you get second
Yes.
opinions, you do whatever you need to do to be comfortable with your decision, but that you continue to make small, even if it's small increments, continue to make some progress, continue to educate yourself, so whatever is holding you up, you're getting the answer you need to get past that.
So I'm just going to ask, there's a couple questions that came in here. One
Mm-hmm,
said, um, here, so they mentioned something about using visceral
mm-hmm.
fat when they're doing reconstruction. I know it's not directly related to radiation, but can you just, I think visceral fat, she means like deep fat, but in terms of fat, fat grafting, how is that used, either in regular reconstruction or to maybe fix a defect in the skin because of radiation? Is that something that you do?
Yes,
Yes.
absolutely. So people, whether it was intended or not, you can actually use visceral fat. People have done omentum flaps for
Oh,
breast
yeah.
reconstruction,
So
and
interesting.
so that is visceral fat. There's no skin involved, so it's a little bit harder to shape, a omental fat, flap,
Mhm.
because it's basically just fatty
And I just want
tissue.
to
But
stop for the audience. Oh, mental fat. Will you explain to patients what
yes.
that is, or people
Yeah,
listening?
so the omentum is basically an apron of fat that hangs down off of your colon and sort of drapes over all of the organs in the abdomen. And so that can be taken as a flap of tissue that has a blood supply disconnected to the body and used to reconstruct the breast. It's used more commonly to reconstruct chest wounds and to reconstruct other defects on the body. It's used quite often for lymphedema procedures, but it has been described for breast reconstruction as well. More commonly, we're using fat grafting, which fat grafting is liposuction of fat, and then it's processed in a simple way to sort of concentrate the fat cells, and then that is injected into the body for a number of different reasons. In a lumpectomy defect, after radiation, if there's some loss of
Mm-hmm.
volume or an indentation or a concavity, fat grafting can be used to fill that. After radiation in the breast, whether you have an implant or a natural tissue
Mm-hmm.
reconstruction, fat grafting has been shown to actually improve radiated skin. So
Mm-hmm.
there's a therapeutic effect to it. And it
Can I ask you,
also,
is it because of some kind of stem cells or,
yeah,
other, or accessory blood vessels? Is that part of it, or?
yep, stem cells. Yep,
Yeah.
exactly.
So
Uh,
interesting.
and so there's a regenerative effect to
Mhm.
fat grafting, and then it also adds volume.
Yeah.
So, I mentioned before that radiation causes a loss of volume. So when we're trying to correct asymmetries after a patient has had radiation, fat grafting is one of the most common tools to
And
achieve that.
is it generally fat grafting, just getting it from like a suction, like a liposuction,
Yep.
or are you actually making an incision?
That's it. It's one of the silver linings to breast reconstruction. Everyone has a little trouble spot that they'd love to get rid of, and we're always happy to target that area. You know, sculpt the area, whether it's thighs or hips or flanks, and then that fat can be used to correct whatever defect or volume correction that we need to improve symmetry in the
And does
breast.
that fat graft stay in place? Does it get reabsorbed and go away? Like does it last? Like how effective is that?
It is effective. You brought up a great point, and this is something that I go through with all patients before they have fat grafting. A portion of the fat that we inject will get reabsorbed.
Yeah.
In the breast, it can be anywhere from 40 up to 60%, so a healthy amount. When we inject fat into other places like the face, because there's such great vascularity in the face, that the reabsorption rate is lower. But in the
Mm-hmm.
breast, let's just call it somewhere around 50%. So if we inject 100 cc's, about 50 is going to stay, and that fat that stays is permanent.
Mm-hmm.
Now, if you overdo fat grafting, you have a higher chance of causing complications like fat necrosis or
Mm-hmm.
oil cysts, and so there is a limit to how much we can fat
Yeah.
graft in each session, and so it's much better to be safer, limit the amount to the safe amount, and
Yeah.
your surgeon has ways of, it's basically by feel. We know when we filled the
Mm-hmm.
area, and any additional fat into that area is just going to be an increased risk for complications. And so there are times that we will actually fat graft a patient more than once.
Yeah.
So if we got a partial result and they're happy with it, and we fell just a little bit short, many times we'll come back to do a second round of fat grafting. It means a little bit more liposuction, which again can be a silver lining. And it's really pretty easy. It's well tolerated. Recovery is quite short. So it's not a huge investment in healing or time for patients. And so often is well received.
Lupron is my arch nemesis
I saw
against
that.
weight loss. Yes, because estrogen deprivation does a lot of things that antagonize metabolism. We could have an Instagram live all about that. That's a big issue. So it can be an arch nemesis. But the good thing is there's new data. I'll just address this. There's new data that's showing that the GLP-1 agonists like Ozempic, Wegovy, these medications are safe for breast cancer survivors, are useful, that they are successful even if they're on anti-estrogen medications and losing the weight, which may help them feel good about their bodies more, regain a little
100%.
bit of control. And also we know excessive weight gain is increased risks of recurrence. So, you're right to be concerned about weight gain. And so that's an important thing. And then when someone else said, Dr. Lee, is there a window within which she should finish reconstruction? So if someone is like, say, let's just use it as a hypothetical because we're not answering personal medical things, but if you say get tissue expanders and, is there a certain time that you have to have them removed, finish up that, or, what's the ideal timing?
So for that example, a tissue expander is not meant to be a long-term device. Patients have them in for over a year, sometimes 2 years, but I certainly wouldn't recommend that a patient go 3, 4, 5 years
Sure.
with a tissue expander. For if it's not a tissue expander, if you have an implant in or you didn't have a reconstruction at all and want to have a reconstruction, or having any kind of complications with your current reconstruction, the good news is there's never a closed door with
Mhm.
a breast reconstruction. There's almost always something that we can do to get it to make it better, or switch you to a different reconstruction.
Option.
Yeah, exactly. And so I think that that's one of the great things that I love about what we do is we can almost always help in most situations. And so if you're not ready now and you need more time,
Mhm.
not a problem.
Yeah.
It can always be addressed in the future.
Yeah, and particularly, really at any age, but if you're on the younger side, what you have done first might be the right thing at that time. And I've
Correct.
met many, many, many breast cancer survivors, myself included, that had, redos or, fixing up or, changing things a little bit with their reconstruction. And that is something you kind of have to know going into it. It's probably not a one and done for the rest of your life. And that's
Yeah,
okay. That's
yeah.
okay.
I mean,
Yeah.
what I tell, especially in my younger patients, is we're we all continue to age. Whether you never had surgery, your breasts will continue to age, and just because you had surgery and there's an implant in there, doesn't mean that there's going to be changes to the skin, to your body habitus. You may gain a little weight or lose a little weight over
You may get
time, and
pregnant. Younger breast cancer patients can get
a
pregnant. You
hundred
see this, right?
percent. Yep.
Hmm.
And so, over the course of 50 years, yes, there's, does there, if there is an implant, eventually it's going to rupture and it's going to need to be replaced. If it's a natural tissue reconstruction, you're going to age, the tissue is going to age, and we may need to do the same thing that we would do for a patient who has their native breast, which is tighten the skin, do a
Yeah.
little bit of a lift, make some sort of correction. And so um, that's another thing that I love about my practice is I have long-term
You
relationships
get
with
to
my
see them
patients.
again.
Exactly. Yeah.
Quick question here. Is there data on risk of recurrence with implants versus no implants versus fat grafting? I think there's probably no difference, but I'll let you answer that.
There is no
Yeah.
difference. So it doesn't matter whether you have no reconstruction, a reconstruction with implants, your own tissue. We add fat grafting later. There's been no data that shows any kind of increase in recurrence,
Mhm.
and so it's whatever decision you choose. Know that it's safe.
And I know this isn't related, but if someone showed up for a live, I'm going to answer their questions. Are GLPs safe for BRCA patients due to the risk of pancreatitis? Really important to know BRCA patients are at higher risk for pancreatic cancer, which is very different than pancreatitis. And most BRCA patients who are not alcoholics and not unhealthy and having other things that may increase pancreatitis, which is inflammation of the pancreas, um, you are not at an increased risk of pancreatitis. And yes, a safe GLP-1 FDA approved version, um, prescribed by someone who knows what they're doing, is likely very safe. And just because you're BRCA doesn't change that. So I'll make them feel good about that. Anything else you want to say to the audience? Otherwise, just tell the viewers how they can learn more,
Mhm.
follow breast, reconstruction
Sure.
org, and yeah.
No, I think we covered the main sort of key topics with
Mhm.
radiation and how it affects breast reconstruction. I think the timing issues certainly come into play, and for some, that's going to be surgeon specific, whoever they're seeing. And I think if what the surgeon is telling you makes sense and you're comfortable, that different techniques are better in different people's hands. Everyone has their preference. But I think that, yeah, I think we covered all the main issues. Our website, breastreconstruction.org, has additional information on on radiation, effects of it on breast reconstruction. And so if there's any questions at all, feel free to reach out. Happy to address specific issues.
Good. And there's a newsletter there. This Instagram Live will be saved on both of our
Absolutely.
feeds. So
Yep.
if you've got friends or family member that you want to send this to, you'll be able to just, you can send them this whole thing just as a message on Instagram in their DMs, or they can just click on our feeds. You also have an Instagram account, Dr. David Light, right? They
I
can
do.
follow me, and I do lots of menopause stuff and breast cancer survivor and BRCA previvor stuff. So and we'll probably be doing more stuff in the future. So
100%.
thank you, everybody, for joining us, and have
Thank
a really
you.
good evening.
You as well.
Bye bye.
Thank you. Bye bye.